Good afternoon. My name is Helena Zazinski. I'm a professor of obstetrics and gynecology here at the University of Pittsburgh in the Division of Urogynecology. I'm a steward of the vagina. That's what the field of urogynecology, in many ways, likes to consider itself and the reputation we have. We reconstruct vaginas after childbirth injury. We build vaginas, as you heard from my colleague, Dr. Pam Awali, yesterday, with skin grafts. We support vaginas. And we spend a lot of time talking about what women do with their vaginas. So I guess it was for that reason I was invited to moderate this next session, which is a segue between women's health, both from a sexual health perspective and some of the other challenges that the peri and postmenopausal woman struggles with as she moves past that childbearing window. One of the other roles that I have, in addition to being a clinician scientist, is the privilege of directing a clinical and translational research center, the first satellite of the Magee-Womens Research Institute, 140 miles north of Allegheny County and Pittsburgh, through truly the vision of Bob Edwards, our chair, and the tremendous support that Yoel Sadowski has had. We've had the opportunity to extend clinical trials to women who, through the barriers of distance and finance, have been now able to participate. We built this program in the midst of the pandemic, and through, again, the tremendous support that we've had, we've adopted 7 studies, enrolled over 270 women in clinical research, and most importantly, we're providing women who are in very agrarian and rural communities and counties surrounding Erie the opportunity for the first time to not only have their voices heard, but also to have access to novel therapies that would otherwise be difficult to engage. So I wanted to say thank you and acknowledge some very important people in that initiative. This afternoon, I have the privilege of introducing 2 speakers for this session. The first is Dr. Cheryl Kingsburg. She is Chief of the Division of Behavioral Medicine at the McDonald Women's Hospital, which is part of the University Hospitals of the Cleveland Medical Center. She's Professor of Reproductive Biology and Psychiatry at Case Western Reserve University. Her areas of clinical expertise and research, as in many clinician scientists crossover, include sexual medicine, female sexual disorders, menopause, pregnancy, postpartum, and mood disorders. She is the principal investigator of numerous clinical trials on sexual health and well-being, as well as the genitourinary syndrome of menopause. She works closely as a consultant with the pharmaceutical industry in the discoveries of hopefully agents that will help women who are struggling with sexual dysfunction. She also serves as an associate editor of the Sexual Medicine Reviews and is the past president of the North American Menopause Society, as well as the International Society for the Women's Sexual Health. With that, please help me welcome Dr. Kingsburg to the podium. Thank you.
Well, good afternoon, everyone. Thank you for inviting somebody from Cleveland to speak. And it is such a pleasure to talk about sex. My topic is midlife sexuality, but it really could be female sexuality is not an oxymoron. Here, let me tell you my disclosures. As we heard, I consult to a lot of companies trying to develop treatments for female sexual dysfunction. I have some objectives, but really what I want to convey when I say that it's female sexuality is not an oxymoron is that historically, women's sexuality has really been given very short shrift. We could date it back to prior to the Victorian era, or whenever it was discovered that female orgasm was not required for conception, and maybe I should have given this talk yesterday, talking more about pregnancy, but as soon as it was discovered that orgasm is not required for conception, women's sexuality went kind of underground. It wasn't important. And so we fast forward to 2021, and sexuality is the latter part of the second day, but it still hasn't quite reached prime time, has it? We have Sex in the City, we have Broad City. If you're under 30, you might know that. And you would think that it's really, alive and well. It's on the cover of every news magazine, but really it has not hit our practices, and our culture still determines what is normal, and that is that women's sexuality has not reached prime time. So let's start with a little bit of a historical perspective on what healthy sexuality is. So when we think about the sexual response, which is true for men and women, or males and females, there have been various models over time to try to help us explain what the sexual response would look like. And those of you old enough to know Masters and Johnson, because now when I teach the medical students, I say, how many of you have heard of Masters and Johnson? Can I have a show of hands? See, some yes, some no. They are the first two in St. Louis to empirically study the sexual response, bringing males and females into their lab. And based on their physiologic research, they said the sexual response has sort of a normal variation, always going in this linear progression, starting from excitement, which is sort of the psychobiologic erotic arousal. With men, there's going to be, or males, there's going to be erections. With females, lubrication, vaginal swelling. With a peak level of excitement, there's plateau, that heightened excitement just before orgasm, which is the release of all sexual tension. And then the body moves to an unstimulated state called resolution. In the 1970s, Helen Singer Kaplan and Harold Leaf, both psychiatrists, both independently said that sexual response is missing the most important organ, and that's the brain. And what's missing was desire in that sexual response. So their model said you begin with desire, the wanting, and then the body becomes aroused and reaches orgasm. And then in late 1999, 2000, an internist, Rosemary Basson, said, here's a slide here of Masters and Johnson showing that there's actually a gender variation, or a sex variation, that while the linear progression is the same in men and women, for women there's an infinite variety of ways in which the response can occur. So that while for men it tends to be, or for males it goes from duration being the only thing that changes, for females you can start from excitement to plateau to orgasm in a variety of ways. So here's a model of 3, here's a graph of 3, but that could be 3,000 different women, or it could be the same 3 women on 3 different occasions, showing that the woman A moves from excitement to plateau. She has 2 orgasms on that particular occasion and drops off to resolution. On another occasion, if she moves to B and plateaus, but that's the same woman, we would consider that fairly normal. We do not expect to be 100% orgasmic. Or on another occasion, she has a different kind of response, a quick orgasm and then down to resolution. Now, if that's the same woman on different occasions, that would be fine. If woman B stayed that way all the time, we would consider to have an orgasmic dysfunction. But for clinicians, it's important to know that there's such a variation that women need to be validated that it's okay, for example, that you're not orgasmic with penetration. I see way too many women coming into my office telling me that their male partner has said there's something wrong with you, because all of my prior partners were multiply orgasmic with intercourse with me. And delusion disorder was covered in another topic, and we will move on. But it is helpful to validate the fact that there's an infinite way for women to experience their sexual pleasure. Anyway, then we move on to 1999 with Rosemary Basson, and her model suggests that that linear progression is not necessarily accurate for many males or females, and that it's helpful to consider the idea that that response isn't always desire, arousal, orgasm, that it can be experienced in a variety of ways in a nonlinear progression, such that that spontaneous desire, that wanting, may not be the start of a sexual encounter or necessary, and it's not necessarily pathologic, that many women will begin their sexual encounter feeling relatively sexually neutral, and they may choose to engage in a sexual encounter or be responsive to their partner's initiation because they know it'll bring them an emotional intimacy, or because they read in Cosmo that it burns 500 calories, and we all know that we have to increase our exercise and eat less. So they begin with neutrality, but as they engage in sexual activity, assuming there's no pain, which will shut down that cycle, and assuming that there's no arguments, or there's not a knock on the door, "Mommy, I need you," that kind of shuts that down. But assuming all of that goes well, then as she gets aroused, the desire kicks in. And we would call that responsive desire. So we don't pathologize it as long as the desire kicks in, because in new relationships, there is that spontaneous drive. And many women in long-term relationships say, "I don't have that drive anymore. I'm not, sitting here in a meeting can't wait to get out of here so I can go, have sex with my partner," unless you're in a new relationship. If you're in an older relationship, you're wondering what's for dinner or what's on television tonight. And so it's important to normalize that and say, well, you may not have that spontaneous, passionate drive, but if with encouragement you can be responsive, we wouldn't necessarily consider that a pathology. To me, that's like going to the gym. So, as Dr. Santoro this morning talked about the importance of physical exercise, I have no biologic urge to work out. I'm not craving it, I'm not fantasizing about it. But I know that once I show up, once I get on the treadmill, my heart rate goes up a little, I work up a little sweat, then the smile comes on my face and I say, this feels great. I'm coming back to the gym tomorrow. And so validating that for women as well, saying you may not have that spontaneous urge, but once you get started, are you enjoying it? That would be a normal response. Instead of women who'll say, no matter how much I engage in, say, mercy sex with my partner, I don't really enjoy it, now we have a sexual dysfunction. So when we think about the sexual response, think about it from a biopsychosocial perspective. Right? You have two psychologists here today talking about biopsychosocial. The way we think about sexual health and sexual problems, we look at it from these sort of overlapping perspectives, overlapping factors. There are many biologic factors that will contribute to healthy or unhealthy dysfunctional sexuality. Certainly, so neuroendocrine mechanisms, basic health and disease will influence our sexual health. Psychological factors, depression and anxiety, we certainly know absolutely contribute to sexual problems. Sociocultural values, religious concerns can interfere with sexual health. And finally, interpersonal qualities. The quality of a relationship will determine the sexual health in that relationship, right? You can have all the biologic urge in the world, but if you don't really like your spouse, you're not necessarily going to want to sleep with that person. Right? On the other hand, I'll see plenty of women who'll come in and say, everything else in my relationship is great. We have, shared values, everything's good, but I don't really have any biologic desire. So let's look a little bit at midlife sexuality and, again, healthy sexuality. The myth is there that at menopause or as we age, we lose our interest in being sexual, and that really isn't true. And we have some research to sort of back that up. Certainly the Midas survey was one that supported the idea that twice as many women at midlife and beyond were still sexually active, and you can see that although the mean age for those that were sexually active was younger than those that were not, the primary reason for not being sexually active was the lack of a partner. And so we know that for most women, it is partner status that will determine whether or not they remain sexually active. And if they are sexually active, they can remain satisfied with their sexual activity well into older age. One book that I thought I would bring up called Magnificent Sex, just because it's a great title as well, was just recently published by Peggy Kleinplatz and Dana Menard, and this sort of is the culmination of years of research studying couples who are having great sex. And the reason I brought it up today was only to point out that, that it was those interested in creating optimal sexual intimacy that really began in midlife. Now, maybe because they had more time, but they were also reaching this plateau that was like, is that all there is? And so they really were searching for something better, and those who put the time and effort into it were able to develop sort of great sex. So now that I've talked about what sexual health is and sort of normal sexual functioning, let's talk about a little bit about sexual dysfunction. We generally categorize sexual dysfunction into four sort of groups, four categories. We look at problems with desire, decreased sexual desire, diminished arousal, that could be subjective but more often genital sexual arousal, the inability or difficulty reaching orgasm, and genital pain with sexual activity, and for midlife women that's often due to genitourinary syndrome of menopause, or GSM. But since I only was given 20 minutes for the talk and I was asked to talk about desire, I will not talk about GSM, but please know that that is, of the four categories, desire and pain tend to be the most problematic for postmenopausal women. So when we think about prevalence, and I hear this a lot from my physician colleagues, well, my patients don't really have any sexual concerns. It's probably because they're not asking. But when we look at prevalence, this study from Preside, which was done over a decade ago already, showed that using a nice US sample of over 31,000 women, 43% of them reported that they had some kind of sexual concern. But when you add in the diagnostic criteria of distress, right, you have to be distressed in order to meet the criteria for dysfunction. We don't want to categorize or pathologize anybody who's not bothered. It drops down to about 11% of the US population will meet the criteria of having problems with desire, arousal, or orgasm, with desire being the most prevalent sexual problem in about 1 in 10 of all women. And it's not just older women. You can see from the age stratification that even the younger women, 18 to 44, had a fairly high, almost 9% prevalence of hypoactive sexual desire. It was the midlife women, 45 to 64-year-olds, that had the highest prevalence, and it could be that they were struggling with changes that were occurring at midlife, and the oldest had the lowest prevalence, and that could be because they were less distressed. Either they had older partners, so they set a lower bar, or they were sort of accommodating to the fact that they were aging and had a lower expectation. So when we define desire problems, we call it hypoactive sexual desire disorder. It is any of the following for at least 6 months, but I will tell you most women coming in with HSDD, what we shorten it to, usually had this problem for quite some time. So it's the lack of motivation for sexual activity. So it's when women come in, they say, I want to want, right? They miss that. They miss the anticipation. They miss the appetite, if you will. And it can be experienced as reduced or absent spontaneous desire, that sort of biologic drive, sexual thoughts, feeling horny, if you will, or even that responsive desire. So it could be either or both. That also includes personal distress. We don't diagnose it unless you're distressed. When we think about how we understand from that biopsychosocial perspective, think about the fact that sexual desire, or excitation, if you will, we think about on a tipping point, right? So Michael Perlman sort of defined sexual desire as, wanting or not wanting, or hot or not hot. And it's important that we have it on inhibition and excitation, because we certainly don't want to have desire all the time. As a species, we would not survive if all we thought about all day long was sex, right? You would not get your work done. We would not have a great lab. Things would not get done. So there needs to be inhibition at the right time. But with women with sexual dysfunction or low desire, they either have not enough excitation, so things on the green side here for go, or they have too much inhibition, right? So we either want to increase the excitation or decrease the inhibition. We have things, thank you to John Bancroft, that we create a sort of a dual control perspective that says there are biologic factors that contribute to sexual excitation or inhibition, thinking like dopamine, oxytocin, norepinephrine, right? Those will help with excitation. And then on the inhibitory side, serotonin, most of you who've prescribed an SSRI would know that that has inhibitory effects. Opioids, endocannabinoids, they work on the inhibitory side. But we also have psychological and psychosocial factors that will create excitation or inhibition as well. So intimacy, shared values, past positive experience, what might lead to more excitation, while we have inhibitory aspects of past trauma or negative relationship factors or stress, right? All of those would inhibit one's sexual excitation. And inhibitors also occur well outside the bedroom. And it's important to know that the impact of low desire is experienced far beyond the bedroom. So women who have low desire also report that it impacts their self-image, it can create depression or depressed mood, and it certainly interferes with their relationships with their significant other. I published this several years ago, doing a survey of women who had reported low desire, looking at how it impacted them. And what's interesting is that 69% reported that it negatively impacted their body image. And most of my colleagues and friends said, Cheryl, you kind of got it backwards. Of course, if you have poor body image, it's going to impact your sexual desire. And I said, no, it's the other way around in this case. Women who had low desire said that it made them feel less attractive. They now felt less feminine, less sexual, and that really impacted how they saw themselves. They also said that their self-confidence across the board, not just in bed, had declined. And it certainly impacted their relationships. 67% said they felt less connected to their partner. 35% said it negatively impacted how they spoke and communicated with their partner, and 35% were worried that their partner was going to cheat. Did I really run out of time?
Yep.
Wow. Okay. So let me finish up with couple of points. When sex is good, it's good in a relationship, but when it's bad, it can negatively impact that relationship way more than good sex can save an average one. Okay? Keep that in mind. I was going to talk about all the drugs that there are for sexual desire, and that this is very similar to the 80s, which is why you see the 80s. Before SSRIs were popular, we thought of depression as all in your head, and once we had SSRIs available, we recognized depression had a biologic basis. Same thing for sexual desire. Without drugs to treat it, even though psychotherapy works very well, the medical community would not see it as a medical condition. So I'm hoping that you will see it as a combination. Here's what we do in psychotherapy, okay? And just as a point, there are 26 plus drugs approved for male sexual dysfunction. There are now 2 approved only for premenopausal women. Flibanserin, which is, this is what women have been marketed. So flibanserin, which is a mixed postsynaptic 5-HT1A agonist and antagonist that has pro-sexual effects. It's an oral medication taken every night. And bremelanotide, which is an auto-inject, it's an on-demand subcutaneous injection that works within about 45 minutes, lasts about 16 hours. Only approved in premenopausal women because regulatory agencies still think that pre- and postmenopausal women are 2 species. These are non-hormonal treatments, interestingly enough, non-hormonal, but only approved in premenopausal women. And then we have testosterone. Please, if you have a postmenopausal woman, we know that although no approval for testosterone, we use it off-label. We have 12 societies that have supported the data supporting its use in Postmenopausal women with hypoactive sexual desire disorder. We have clinical guidelines of how to use it. I'm happy to talk about it in discussion. The ISWISH clinical practice guidelines talk about using 1/10 of the male dose. And with that, a combination biopsychosocial model, treating with psychotherapy. I do it for a living. Biologic, pharmacologic options, very nice as well, and the combination. And so, sorry I went a couple minutes over. Thank you very much for your attention.